Awesome. All right. Thank you. Very good evening to all of you. Although it's 4:45 a.m. in the morning in California. First of all, I would like to thank the organizing committee, Dr. Hari Krishnan, Dr. Kartha, and Dr. Jayakumar for organizing this and giving me the opportunity to be a part of this heart conflux. And so the topic which was assigned to me was signaling mechanisms of transition from cardiac hypertrophy to heart failure. Although although we know that we don't have a definitive answer that how it changes from cardiac hypertrophy to heart failure, but I would definitely like to discuss the different signaling mechanisms which are involved in this transition. um, to talk about the diverse pathological stimuli which leads to heart failure. We all know that there could be genetic reason to it, and myocardial infarction being the number one. Then we have pressure overload and volume overload. It could be related to aging. We have different cardiomyopathies, diabetic cardiomyopathies, and so there are different diverse pathological stimuli which can lead to heart failure. And all these stimuli can produce all hemodynamic alterations with relation to the volume of the blood and pressure of the blood. So that can lead to cardiac hypertrophy and heart failure, which is also associated with different abnormalities. Now, that could be hormonal imbalance. We have increase in different vasoactive hormones. We have metabolic derangements, which is with regard to substrate oxidation and utilization. Then we have alterations in the extracellular matrix, which is in regards to fibroblasts and other kind of cells. Then we have calcium handling abnormalities, which is because of sarcolemma or sarcoplasmic reticulum, which actually originate from that organelles. Then we have oxidative stress, which originate from mitochondria and the production of NADPH. Definitely reduction in capillary density, which is because of disproportionate development of the capillary bed. Then we have inflammation, which is because of the cytokine production, and then all that leads to ventricular wall tension, increase in the ventricular wall tension. To talk about the number one cause of heart failure, which is myocardial infarction, we know that that leads to the formation of infarct and the loss of myocardium. And that kind of activates the sympathetic nervous system and renin-angiotensin system, which will further make the release of all these vasoactive hormones, angiotensin 2, catecholamines, epinephrine, norepinephrine. So, and all these hormones then will increase the ventricular wall tension. Now, of course, that is happening. And then, because this is kind of, I would say, it's a compensatory mechanism for the heart to deal with that stressful situation which happened because of infarction. Now, that will actually lead to the synthesis of protein in the non-ischemic myocardium. So the one which is infected, and then we have the one which is not affected, and it is viable. So that will lead to increase in protein kinases and protein synthesis, which will cause hypertrophy, which means increase in the muscle mass. So that's kind of a compensatory mechanism. On the other hand, we also have, as hormones have increased, that cause constriction of coronary blood vessels and functional hypoxia, again because of disproportionate capillary bed development. And the mitochondria releases certain monoamine oxidases, which can cause oxidation of catecholamines. And then, of course, angiotensin 2 is activated because of NADPH. All these causes formation of oxyradicals and like superoxide ions and hydroxyl ions, which is kind of creates a situation of oxidative stress. Now, one thing I need to mention here is that we know that at initial stages of, let's say, acute myocardial infarction, or maybe initial stages, or let's say physiological myocardial infarction, that time we have antioxidants in the heart to support the oxidative stress. But in the later stages, the oxidative stress comes kind of overpower. That is what causes the transition, causes the problem, and leads cardiac hypertrophy to dysfunction and eventually to heart failure. To talk about another mechanism, which I mentioned in the first slide, that we have pressure overload and volume overload, which also causes, like, because of hypertension and valvular regurgitation, all of these leads to ventricular wall tension again, and release of hormones. So now here we have endogenous release of hormones as well, and as well peripheral release of hormones as well. So we can see there is endothelium release, endothelin, and then we have endogenous norepinephrine, angiotensin, and then all these leads to hemodynamic alterations, and the hormonal level is again at increase, and this can again cause oxidative stress, which will eventually convert the silent cardiac hypertrophy to again into dysfunction and eventually to heart failure. Now, we know that if this stimulus is prolonged, which means we have increasing levels of hormones and growth factors in circulation for longer duration, that again, as I mentioned initially, that will actually causes, of course, disproportionate capillary bed development. But another important factor to consider here is that actually it leads to the I would say the imbalance between the cytokine production. So pro-inflammatory cytokines and anti-inflammatory cytokines, the balance is disrupted, which actually leads to the formation of accumulation of, I would say, collagenous material in the extracellular matrix. And on the other hand, we already have that oxidative stress being built up. And that oxidative stress and plus the collagen material, which is started to develop in the extracellular matrix, will actually cause, so oxidative stress will release proteases like metalloproteases, and that will actually cause the degradation of those collagen which was being built up in the extracellular matrix. And that again is another reason for the transition of cardiac hypertrophy to heart failure. So we can see that there are multiple factors, and all of these are correlated in one way or the other. But as we are seeing from all these three slides, and the oxidative stress is the major factor. Then again, if we talk about overall picture, now we know that so the vasoactive hormones levels is increasing in circulation, and of course there is activation of fibroblasts and macrophages in the extracellular matrix, and then even within inside the cardiomyocytes there is alterations. Okay, so extracellular matrix is being compromised, and then we also have myocardial metabolism, altered myocardial metabolism with respect to energy utilization, more fatty acid oxidation, and the accumulation of cation homeostasis changes. Specifically, we have calcium, sodium, potassium, and there is calcium overload, which all causes changes in the energy production, how mitochondria is producing energy. And of course, cardiac gene expression is altered, and several proteases are activated, which causes cellular remodeling with respect to sarcolemmal structure and influx and efflux of calcium. And all this leads to cardiac dysfunction. And of course, oxidative stress was already coming in. And that can again lead to loss of cardiomyocyte and eventually to heart failure. Now, just to look at how this two aspects which we need to look here is that these vasoactive hormones, all these endothelin and epinephrine, norepinephrine, what they do is basically the alterations in cardiac metabolism, as I mentioned, that the substrate change, there is increase in the oxidation of fatty acids, which is kind of deleterious for the heart. And then of course we have calcium handling defects because of the pumps, the sodium potassium ATPase and the sodium calcium pumps. There's a different, and then also because of the increased vasoactive hormones, there is receptors which are activated, and that causes increase in flux of calcium inside the cell. So we can see that from all the specs, the calcium handling defect is also compromised, and that leads to increase in intracellular calcium, alterations in cardiac gene expression, because there is some research which says that this calcium can enter the nucleus as well and cause alteration in cardiac gene expression and promotion of apoptosis and necrosis inside, and activation of certain proteases, specifically calpain, and that leads to cardiac remodeling with respect to size and shape, and eventually leads to heart failure. Another thing is, again, cardiac hypertrophy, which we know has been caused because of elevated level of plasma vasoactive hormones for longer duration, which means now our physiological heart failure has been, not heart failure, physiological hypertrophy has been kind of shifted to pathological hypertrophy. And now the myocardium has been increased in mass, but the capillary bed is not proportionate. And that leads to hypoperfusion of myocardium. Oxidative stress is caused for sure, and inflammation is caused. So one thing I would like to again kind of summarize here is, so the imbalance between cytokine production, like TNF alpha and TNF beta and all those interferons and interleukins, and the imbalance causes inflammation, and the imbalance between antioxidant reserve and the formation of free radicals, that leads to oxidative stress. So inflammation and oxidative stress together then cause kind of a vicious cycle. We have fibrosis and the extracellular matrix. It can also be inside. And then we have apoptosis and necrosis because of loss of cardiomyocytes, which is stemming from inflammation and oxidative stress, activation of certain proteases, which will further causes subcellular defects in sarcolemma, sarcoplasmic reticulum, myofibrils, mitochondria, and extracellular matrix defect. And all this again leads to remodeling of the heart and leads to heart failure. So at what stage we find that or pick that up is exactly the need of the hour. We need to find out what is happening. And I know there's a very fine line between this transition, and that's why sometimes it's left undiagnosed, and we are not able to find out at the exact stage when this physiological hypertrophy gets changed to pathological hypertrophy. Then again, so this is kind of a summary this is what I've been saying. So we see that oxidative stress is central. So we have a lot of, pathology. There's different kind of stimulus, which is because of the activated vasoactive hormone, and that stimulus is there for longer duration. And now these hormones is kind of doing all their functions. There's a hypoperfusion of myocardium. There is activation of NADPH, which starts to do oxidation, and then activation of monoamine oxidase again in mitochondria, mitochondrial dysfunction because of increased calcium overload. And so the ATP production is compromised, and also there is extra ATP hydrolysis. So kind of energy deficient state is there, and again that will all will lead to oxidative stress, which will do its function. And that is what we need to control. Oxidative stress, I know there are a lot of medicines which target the hormones. We have antagonists, different hormone antagonists, but we really need to target oxidative stress. That is what I know. A lot of a lot of vitamins, minerals, and several other sulfur-containing compounds have been used, but we don't have a very, very strong, definitive answer to this oxidative stress as of now. And that leads to cardiomyocytes, loss of cardiomyocytes, which eventually lead to apoptosis, necrosis, and fibrosis. And then, of course, depression in energy production, cellular remodeling, and that is a transition of cardiac hypertrophy to heart failure. So that's kind of different mechanisms. What is the need of the hour? As I mentioned, that we have been using antioxidants in preventive cardiology, but what I think is required is, because we see that we need definitely novel interventions and pharmacological approaches which target multiple mechanisms at the same point. That is what is important. Yesterday also I was listening to the talk, and there was one speaker who mentioned that it's not just one target which we need to focus right now. We have to think about how we can target this disease, targeting a different multiple targets, molecular targets. And then, of course, I think bioactive compounds, which are the physiological active compounds present in low quantities in plants, they have the potential to kind of attenuate this oxidative stress. But at the right stage, what is the stage? That is what we need to find out, because there's very, very fine line, as I mentioned again, that in this change. And then resveratrol, I think has a potential, and we definitely, and this is what I'm kind of starting to do in my lab now, and wanted to see that how it can impact the the prevention, or maybe the attenuation of the oxidative stress at the right stage. That is what is important. So as I always say, thank you so much for listening, but this is what I always feel, and I think this is, I believe in: never let success get into your head, and never let failure get into your heart. So I mean, we have to, as a nutritional biochemist, I think we can, although some things are not under our control, but definitely certain things are under our control, and we can, with our diet, with our physical activity pattern, and we can definitely make sure that failure does not get into our heart somehow. Thank you so much.
Thank you, Dr. Kaur. That was a very good talk. I'll just take off the first question. Now, in terms of COVID, which is there right now, and COVID, we are seeing a lot of heart failure. In fact, out of the admitted patients, almost one-fourth of the admitted patients have heart failure. And
Yeah.
we at AIMS are now starting to see post-COVID heart failure. Are there any mechanistic studies being done in COVID-related heart failure? Because we are seeing COVID, we are seeing cytokine storms,
Yeah.
we know that there is some relationship to angiotensin 2 also.
Yeah.
So are there any COVID heart failure models which are being created to look at the mechanisms? Are there any lab models?
Yeah, it's a very good question, because it's comparatively, we know it's comparatively newer, but I'm very sure that people are working on it, and they have started to create models. With COVID, the problem is, again, as of other different kinds of heart failure, that we have acute heart failure is happening. And specifically in children, I have seen certain cases that COVID antibodies are found in the hearts of the children who have acute heart failure. So yeah, so but I'm pretty sure research is being done. We don't have a very, very definitive data as of now, but yeah, people are working on it for sure.
Okay.
Thank you.
There's one question from the audience. I think Dr. Shakti, well, he's posed a question that are
Yeah.
there any markers for transition from heart failure preserved ejection fraction to heart failure reduced ejection fraction?
There are markers. Definitely, there are markers. But again, we have wide array of markers. We don't have very definitive answer. Is there a specific marker which is kind of is if this is amplified, we know that there's a transition happening. As I mentioned, there's a very fine line, so we don't know if so we have to look at multitude of factors. There's not just one marker which will tell us that okay, there's preserved ejection fraction, or increased ejection fraction and all those things. Yeah.
So let's move on to the next talk, please.
Thank you so much.
Thank
The
you very
next
much.
speaker is